Right, so there's been a lot of discussion, obviously, already in the meeting about PML. Gordon's given you some excellent case and very candid case histories earlier, which have covered some of the issues, and some of the questions from the audience have reflected the angst and the psychological impact of managing patients with iatrogenic complications of RMS therapies. So obviously that's the reason why I think the steering group on your behalf have focused on this as being a major topic for this meeting. And in some ways, PML is the neurological perfect storm. So it's a neurological complication of neurological therapies. Clearly, PML exists in other illnesses outside of MS and with other therapies, cancer in particular, and transplantation medicine and so on. But in our practice, obviously, it's of particular concern. And of course, it's managed by neurological teams. And as I think Gordon very candidly described, sometimes, unfortunately, you see the consequences of your prescribing day after day after day after day, month after month, as an inpatient with some people who unfortunately don't improve. The disclosure statement is on the website, and in relation to this particular talk, I think one of the reasons I may have been asked to give the talk is because I, like Paul, was involved in a group that looked at the evidence at the time for stratifying risk based on patients exposed to natalizumab. And we published that in 2016. And you know, as I say, whenever I give a talk in MS, you almost have to look up the latest the night before because things seem to be changing so rapidly recently. So in terms of what I'm going to talk about, Paul, I think, has talked largely around a little bit about avoidance and surveillance. Gavin, Olga and Rachel, I think yesterday, did talk about sequencing, and I think there was at least one slide on the proposed bridging therapy paradigm that Barts were adopting at the time. You can tell me if they're still doing that. So I'm going to concentrate largely on diagnosis in a practical sense, and also a little bit around management. And as I said, if there are any specific questions that can't wait till the end, please do ask. This is for your benefit, and I'll try and be as open and as thorough as I can whilst keeping to time. So this is the first case, and some of you will have been to the MS Trust meeting where my colleague Paul Talbot talked at some length about his two cases of natalizumab-associated PML, and he's very graciously agreed for me to share those with you today, and I'm going to give you a kind of an abbreviated summary. So here's the first case. So you are called about a 41-year-old lady with multiple sclerosis. She was diagnosed based upon a myelitis and a brainstem relapse with a GAD-enhancing lesion within a year. So she had res MS. She commenced natalizumab 4.5 years previously. 3 years ago, she had a bit of a blip with some left sensory and cognitive problems, but in fact, those were investigated satisfactorily. And that reminds me to say that fortunately, in our clinical practice, most of the times that we get concerns about patients with supposedly new symptoms on highly effective therapies, it's a false alarm. And I think we all recognise that. But nevertheless, we have to follow the process. And thankfully, in most cases, we can reassure the patient. But there is angst on the patient's behalf and on our behalf for a considerable time. So this all settled satisfactorily. 9 months ago, or 9 months prior, she was found to be JCV positive with a high titer of over 3. And we went to 4 monthly MRI scanning. Her EDSS on treatment, very much like Gordon's case, I think, or one of them, was 0. So this patient had a normal neurological examination. And then she presents with a 2-week history of intermittent left sensory and visual symptoms. So we've invested in a highly sophisticated and individualized audience response system. My one looks like this. 2/3 of you or 3/4 of you will look like that. Okay, so we're all friends. No one's recording your individual answers. So what do? Do you reassure her that this isn't PML because the symptoms are intermittent and her MRI scan 4 months ago was reported as normal by one of your in-house neuroradiologists? Do you defer the natalizumab and order an urgent MRI and consider a lumbar puncture, or do you do something else? So hands up for number 1. Okay, that's good. My work here is done. Number 2, defer natalizumab and order an urgent MRI and consider a lumbar puncture. Yeah, okay, so this is the one I'm interested in. Who would do something else? Please, why would you do something else and what would you do? Okay.
But if I was considering a lumbar puncture, it might be for JCV serology as well.
Right, okay, so just in terms of the JCV, just to be clear, you'd repeat the blood JCV, or you would repeat the, you do the JCV and the CSF, or both?
I might consider that if depending on the brain. We'll probably do the brain MRI, because if it was urgent, it wouldn't cause much of a delay.
Okay. So I know Paul talked about human error yesterday, and I've independently had a slide about human error and people's results being mixed up and so on. And I think we have somebody that's on natalizumab for a long period of time who are serially JCV antibody negative, and then they suddenly have a very positive result. I could understand before you made what could be, as Gordon has described, quite a major decision in terms of switching therapy based on one result. You may want to repeat the serology to make sure that the samples weren't mixed up or whatever else, and these errors do happen. But for the purposes of the presentation, if we assume that she is definitely JCV antibody positive in the serum at high level. Yeah? There was one other person that would do something else. Did you want to comment, or shall I move on? No? Yeah, please.
I was just going to say, actually, if you've got the scans there, actually look at them yourself.
Yes. Absolutely. Right. So this is exactly the point. So for me, the concerns here are, we obviously know that she's at highest risk because she's had more than 2 years of exposure to natalizumab. She has high JCV positivity, notwithstanding what I've just said. And, you know, when you do get these apparently anomalous results, it's always worth repeating the test, but going on in parallel, as your colleague said, in terms of checking this, either repeating a scan or going back and rechecking the scan yourself. And that's an absolutely crucial point. And also the fact that this patient was doing so well. So now we've got these left visual symptoms as well, which appear to be new, that haven't been present previously. So on that point, if I just say to you, the symptoms that lady described initially were kaleidoscopic effects, which obviously could have been a migrainous phenomena, but in fact occurred in both visual fields. So for those of you that manage patients with stroke, you'll be aware of what an homonymous field defect is, but essentially the inner half, the nasal half of one visual field and the temporal outer half of the other visual field, or vice versa. Those symptoms continued, and the patient then had a problem with depth perception as well and reduced visual acuity. And she described gaps in her vision. So as my colleague said, those were atypical symptoms and therefore required further investigation. Just before I come on to the MRI, because you're absolutely right, just in terms of trying to conceptualise the difference between the two, I think we're all very familiar with MS relapses, so I'm not going to labour the point there. But, and this is my sort of interpretation of the shape of PML symptoms, if you like, there is a clear asymptomatic stage. And in the various studies, it's in the order of 4 to 6 months, where there will be changes on an MRI which aren't necessarily reflected by clinical symptoms. You then have a period of inexorable worsening, so symptoms do get worse, and they don't plateau and they don't improve in the same time course and in the same way as an MS relapse. And that's one of the things that you should be aware of in practice. So if I just take a quick aside and say that we all have patients who ring every week, every day, almost, and in fact my case of PML paradoxically happened in a lady that was just like that, and the fact that the symptoms didn't settle and she kept ringing and ringing and ringing, you do have to desensitize yourself from the emotional aspect of it and focus on the fact that you can't disregard it in these high-risk patients. And then there is also, as Gordon mentioned earlier, the immune reconstitution inflammatory syndrome, and that in itself can cause a worsening in disability and a worsening in outcome, and we'll come back to that hopefully at the end. So these are the atypical symptoms associated with PML that we need to be clinically vigilant for. Aphasia, problems with speech, behavioural issues. I mean, every time I say this to patients and there's a partner with them and I say, any changes in his or her mood, you need to, and at this point they're a big smile on their faces, but you know, anything that's out of the ordinary for that particular patient. Neuropsychological and cognitive alteration, the so-called retrochiasmal visual field defects, which I've just described, that homonymous field defect, inner half of one visual field, outer half of the other. Hemiparesis and seizures. So hemiparesis or hemisensory symptoms, again suggesting contralateral hemisphere, and obviously seizures are described in MS, but are relatively rare. And again, new onset seizures should always make you concerned and wonder, and you saw Gordon's case. So the question I have for you then, because your colleague was exactly right, you do the MRI scan, and is the scan normal or abnormal, and if so, where? And I'll give you a clue. The scan should be more or less symmetrical. So just review the areas on the scan, and would someone like to tell me whereabouts the... Yeah? Okay, right, so I'm glad you noticed that. So your colleague made an excellent point, and this is the crucial point. So we have high clinical suspicion about this patient because they have atypical clinical symptoms on a background of being at highest risk for developing PML on natalizumab. And apparently the MRI scan, the last time they had it done 4 months ago, was normal. And Gordon alluded to that in one of his cases. Can you see the abnormality on the scan 4 months previously? Okay. I think Paul went into some detail around the issues around human error and some of the reasons why that might be the case. I just make the point that I think we're all saturated, or we're all becoming saturated with more complex patients. There's a lot of work from the MS Trust, obviously, on MS nurse caseload. One of my colleagues sent me a long, detailed email about MS consultants' caseload last week, and perhaps we should be starting to argue that we safely can only manage a certain number of patients. In terms of the MRI protocol for PML screening, so this is the PML lesion here on the flare sequence. So T1 sequence is PML looks black. So CSF looks black, and it's mainly for anatomy, T1, okay? T2 sequence is CSF looks white, and the PML looks white as well. Now, obviously, you can see that, and that looks pretty obvious that there's something abnormal there. But imagine if there's small changes, and we'll show you some of those in a bit. The flare image is a T2 image with the water, i.e. the CSF, subtracted. So that minus the CSF is that. And you can see why flare is much more sensitive in picking up changes associated with PML. And the diffusion-weighted imaging as well is, again, important in terms of being able to show this up. So for the PML screening, all we're really keen on knowing is not so much the anatomy, but actually whether or not anything has changed since the previous imaging. So most specialist neurological centres now will have this type of screening protocol, particularly for the patients that are being screened on a very regular, more than yearly basis. And for detection of PML, once you've gone through the screening stage, then obviously you may well want to look at a post-contrast scan and so on. And as you'll know, it's difficult to get contrast scans on a regular basis. because they're more costly, they take more time, and also there's been some concerns recently about deposition of gadolinium in the basal ganglia, and I'm sure you'll all have patients that have refused contrast for various reasons. So, again, just to labour the point, this is a case study of a different patient, and you can see the very subtle change there from January 2018 and over 6 months, how that progresses. As Gordon's case demonstrated, this is called scalloping of the cortex. So the PML will normally start in the white matter and then spread to involve the grey matter. And in this case, you can see the grey cortical ribbon is preserved, at least initially, because as you come down sequentially, you can see the consequence of a delayed diagnosis and management. But you can see that it can be incredibly subtle. And in fact, what I remember, this is obviously the basis of a lot of the so-called carryover PML cases. In other words, cases which develop on one disease-modifying treatment, and statistically that's usually natalizumab, and then the patient has another treatment, and the PML symptoms become apparent, and then the clinical team go back and re-look at the previous MRI scans, as your colleague suggested, and find actually that the lesion was present before the patient switched from natalizumab. Okay, so this is the basis of this so-called carryover PML, which is described with a number of our current treatments, obviously. So this is the MRI pattern for PML. T1 black, T2 white, diffusion-weighted imaging high, flare high, and if you do get on the T1 images very white-looking changes, even outside of contrast, then you need to be thinking about iris, and I'll show you some of those changes in a moment. So you've got the clinical, you've got the radiological that you think this looks highly atypical and very consistent with it being PML, needs to be ruled out. What do you do next? So, raise of hands. 1, repeat the MRI in another month. 2, lumbar puncture and send CSF to your local microbiology laboratory. 3, lumbar puncture and send CSF both to your local laboratory and to a reference laboratory as well, which is likely to be commercially sponsored. Or 4, a brain biopsy. So who would do number 1? Okay, good. Who would do number 2? Excellent. I may as well go home. Who would do number 3? Yeah, perfect. And who would do number 4? Who's very invasive? Who's a latent surgeon? Thankfully, none of those. So what we've got, this is the American Academy of Neurology proposed diagnostic criteria for MS for symptomatic cases. So we've got compatible clinical features, that retrochiasmal field defect, okay? We've got compatible imaging findings, that right-sided occipital cortex scalloping lesion, and we do the CSF, and if it's positive, we go from possible through to definite, okay? So assuming, of course, that there aren't any other confounding factors, which I hope I'll be able to cover in a bit. Now, for the purposes of the presentation, let's say that the patient was negative at your local laboratory. The question is what you do now, and I think you've all said, basically, that you would send it to the reference laboratory as well, and I would absolutely agree with that. Because there's the issue of what the sensitivity is in terms of the individual laboratories, in terms of what copy number the laboratory will be able to detect. So most of the good laboratories, and certainly our local one in the UK, will go down to about 50 copies of JC virus in the CSF per mil. The reference laboratories will quote a sensitivity of around 10 copies of JC virus per mil. Remember, Gordon's case had, I think, 33 copies, so it's likely he sent that to the specialist laboratory. So you may have a false negative result if you only send the result to the local laboratory. And on a more mundane practical point, if the sample does get lost or is inadequate or whatever to one laboratory, you may then be able to get the result from the other, and that may speed the process of diagnosis. So it's a good way of covering all of the bases. So This will make you rest happily and sleep happily tonight. What is the likelihood that the CSF JCV test will be positive if the PML lesion is 3 millilitres in volume? So this is the PML lesion. Apologies, it's got a sort of yellow halo around it because MRI researchers love colouring lesions. Okay, that's what they do. So is it A, or number one, 100%? Is it 95, 75, 55 or 35? So who's optimistic? Who thinks it's 100%? Okay. Good. 95%. Okay. 75%. Okay, a few takers for that. 55%. About the same again. And who's really bleak? Who thinks 35%? Okay, so we've got a few takers for that. So, what's the answer? Okay, it's a flip of a coin at that point. Okay, so and this study was done sending CSF to 4 different laboratories, including the reference laboratories that we would use in Copenhagen. Okay, via the commercially sponsored assay. So 55% sensitivity probability for a positive JCV virus on PCR in the CSF for 3 mils. That's what a 10 mil or composite 10 mil lesion looks like, 80%. And it's only when you get to that, which by that stage, that's probably eminently biopsyable actually, but again, you defer that, but there is a 1 in 25 chance that you may have a false negative. So what happened to this patient? This lady was plexed. She had steroids. She had all of the treatments that Gordon mentioned, the metazapine, the mefloquine, subsequently had Mariviroc. One of the interesting points about this case was the fact that the lady never developed radiological iris, which I'll hopefully have time to go on to in a moment. But unfortunately, she continued to get worse. And like Gordon's case, unfortunately, she had respiratory problems, went to intensive care, and she succumbed. And on the post-mortem demonstrated clear-cut and very extensive changes associated with iris, which weren't reflected actually in her MRI scans. So that taught us a valuable lesson for our first case. And I should stress the point that that lady had standard interval dosing for natalizumab. Case 2, again, courtesy of Paul, 45-year-old lady with MS, diagnosed 4 years previously, 2 episodes of myelitis, and she had new brain lesions. Commenced natalizumab 3.5 years before, high JCV positivity again, no relapses and no new MRI lesions. So we've been advocating extended interval dosing for a number of years now, based on a number of small case series where it appeared that the efficacy of natalizumab was preserved at least up until 8 weekly dosing. So we've offered patients at 2 years who are JC virus antibody positive on treatment with natalizumab an opportunity to go to extended interval dosing. And obviously, as other high efficacy treatments have come on stream in the last 3 or 4 years, we've then offered patients the opportunity to switch to those treatments as well. Okay. So she went on to extended interval dosing actually in March 2015. She went to the 4 monthly MRI head scans with the DWI and FLAIR sequences that we've just shown you. And then 2.5 years later on extended interval dosing, at 8 weeks, she develops a 2-week history of intermittent right sensory, expressive dysphasia and unsteadiness. Does that sound familiar? So what would you do? I'm going to cut through this because I know you've already said what you would do, and you'd be absolutely right. You defer the natalizumab, you do an urgent MRI head and a lumbar puncture, CSF to both local and the reference laboratories. So I hope you can see that. So the question is yes or no, okay? Is this a recognised appearance of PML? Hands up for yes. Okay, no? Sorry, who said that?
Sorry,
Please.
I said it looks very patchy, whereas
Yeah,
normally
yeah.
it would be quite significant, sort of condensed sort of mass.
Yeah.
This is patchy.
That's a really excellent observation. So if I call patchy punctate, okay, then that's exactly what it looks like, doesn't it? Can you see all of these little spots and things? So that's in fact very well recognised for PML/iris, and we'll come back to that in a moment. So these, you can see this more obvious lesion at the front that, as you've said, kind of looks more coalesced, if you like. But can you see all these little sort of satellite stippled changes here? Again, punctate, patchy, however you like to describe it. This, again, is very highly suggestive of PML. And the location of these is actually in the perivascular spaces, so the so-called Virchow-Robin spaces. And again, just in case I get censured at the end in terms of time, there are specific cells, specific lymphocytes, which have a surface marker for CCR5, which are associated with being in this particular area, these areas of the brain, these perivascular spaces, and are associated with iris. And it's the CCR5 blocker, Mariviroc, which is often used at the iris stage to try and contain the degree of iris, the degree of immune reconstitution that occurs when you stop the Tysabri, and in particular if you Plex, if you plasma exchange the patient, which accelerates the withdrawal of the Tysabri, if you like, from the body, and therefore the immune reconstitution, which we'll come on to in a bit. So this is absolutely well described, and you can see why they call it the Milky Way appearance, yeah? I think it's fair to say we had to remind our radiologist, our neuroradiologist, of this appearance. So again, this comes back to the point that perhaps sometimes we're in a better position to be able to inform our colleagues rather than expecting our colleagues to inform us. And if I just make an observation that because of the number of scans that are being done now, often the scans are being reported outside of the centres by people that you don't have any direct professional contact with. So be wary of a, inverted commas, normal scan that's been reported if the clinical scenario does not fit with the report of the scan. That's a general point. So 1 month after diagnosis, this. Okay, and can you see also the further changes that occurred? The CSF was positive for JC, 37,000 viral copies. Now, this is the point that Richard Nicholas coined this phrase about what's not in the books. And I think that's a very good point in this case. So this was us learning from the first case, and particularly my colleague. And so there was a lot of discussion about whether this patient should undergo plasma exchange and when and if the patient should require steroids. And I would argue that those are probably the two big questions that you'll face in your teams if and when you get another case of PML. We'll talk about the evidence for Plex in a bit, but my colleague decided not to Plex the patient, so to allow the immune reconstitution to come up more gradually and to withhold steroids, but did give mirtazapine and Mariviroc, as Gordon mentioned. The clinical worsening was approximately 6 weeks after the original presentation, and at that point the CSF JCV was less than 50, down from 37, which suggests that the immune reconstitution had occurred and that effectively the immune system had then killed off a good proportion of the JC virus within the CSF. The MRI improved, so there was a lag of another month in MRI improvement, and there was a lag of 6 months for clinical improvement. However, and as Gordon identified in his case, the patient had developed new lesions consistent with MS. And so the question was what to do with that patient. And I would say, this meeting is called At the Limits. 10 minutes, brilliant. So that will be the issue, I think, for next year, perhaps. What do you do with these patients after they develop PML? She went on to glutathione acetate, and just to show you briefly, the yellow are timed walks, the blue and the greens are peg tests, and you can see that although she did deteriorate and she's come back, she's not where she was previously. And I know Karen and I was just discussing the fact that this lady's unable to work currently. So our learnings are human error is inescapable, okay, at many different levels, as Paul suggested. You need expert staff, you need consistent staff. A lot of our patients are extremely difficult to assess. I know, of colleagues in the audience, and some of our Tysabri patients have cognitive impairment. The key point is to know the patients extremely well. And this is one of the paradoxes where, and I hope I don't get pelted with rotten tomatoes, but the infusion nurses probably know your Tysabri patients better than you do because they see them more frequently. So that is absolutely crucial. And when managers are trying to get more generic, peripatetic nurses, everyone doing a bit of everything, particularly in terms of the infusion service, that's your pushback. And so, and I make that point, innovation through adversity. We've been able to make some significant changes in our centre based around the first case. Unfortunately, that then leads to a defensive culture where anything that looks even slightly atypical we're now told about. You can make an argument as to whether that's a good or a bad thing, but it means that we end up investigating an awful lot of our patients more frequently, and thankfully most of them are false alarms. Extended dosing, there are challenges with that. Again, we've had a patient recently that was on 8-weekly dosing. They reported apparently some new symptoms, which I don't think were new symptoms in retrospect, but they, zero tolerance policy, takes another 2 or 3 weeks to get the MRI and the lumbar puncture done and the results, and in the meantime, the patient relapses. So, it's a difficult situation. And if in doubt, repeat the tests. So if anyone wants to take a picture, this is the key take-home point from the lecture, essentially. And you've got the reference there. It's a very nice article, review article of the last decade of PML learnings. Okay, but it illustrates exactly what we've just said. If in doubt, withhold the treatment, repeat the tests, and look at them yourselves, as your colleague said, which is really helpful. Gordon mentioned this briefly. This is the latest update in terms of number of cases. Gordon's mentioned the 825 with natalizumab. Fingolimod have had a number of carryover cases from PML because obviously there was a vogue to switch patients certainly a few years ago before there were other options available. But there have been 30 confirmed PML cases not attributable to natalizumab. DMF, 8 cases so far, 2 of which have had lymphocyte counts of 0.8 or above. So it's not always the patients that have the lymphocyte counts between 0.8 and 0.5. One of the patients was older, was 66, and there may be an issue around immune senescence, which I think Gavin talked about a case yesterday. And that may well be the case with what Roche, I think, have termed confounded PML. In this case of a patient that had MS for 30 years and had baseline slightly low lymphocyte counts, grade 1 lymphopenia, went on to Ocrevus and has developed a confirmed case of PML without any previous disease-modifying treatment. So that has a practical implication for us in terms of treating particularly our progressive patients who are likely to be older with high efficacy treatments. We need to think about that very carefully and make sure that we have appropriate screening in place. There has been one case with teriflunomide and alemtuzumab, which I won't go on into for time purposes. I just wanted to just mention, I won't be able to go into this case in detail, but just to say that we had a case of a patient who basically was on Tysabri, high JCV antibody positivity, wanted to go on to Lemtrada, was very clear that she wanted Lemtrada, works in research, had spoken to a number of colleagues and was absolutely fixed on that's what she wanted to go on to next because of the accumulation of disability before she went on to Tysabri. Does anybody know which item of the lumbar puncture results is missing there? Anyone do lumbar punctures? Okay, for the interest of time, we had a blood-stained CSF. And what that effectively meant was that we had a potential contaminant. So the JC virus in the serum was positive. We're collecting CSF, but some peripheral blood contamination occurs. And so we had a negative result in the local laboratory, 50 copies per mil or higher, but in the commercial laboratory, 11 copies per mil. Okay? We had to repeat the CSF. We got a negative result. Then basically, because we had taken some time to obviously get the patient switched over, she then had an MS relapse. And then I had to give her steroids and sort of keep a very close eye on her to see that she responded in the way that I would expect, and I showed you on the graphs. The take-home point was we ended up with 4 lumbar punctures with this lady to try to switch her as safely as we possibly could. And just remember that CSF sensitivity for early PML in terms of that 55% for those 3 mil lesions, because this is an issue and it caused a huge amount of angst. I'm pleased to say that we're about 18 months down the line now. She's had 2 pulses of alemtuzumab and is doing well. The last thing I want to talk about, I know we're right on the nub, is plasma exchange. So do go and have a look at the ECTRIMS website. It's a brilliant resource for a lot of the webcasts. So if you didn't get to ECTRIMS and you want to update yourself, Chris McGuigan presented this data on behalf of the investigators that had submitted information to Biogen, okay? And again, to be very quick, 85% of the patients were plexed, 15% weren't. Generally speaking, you are more likely not to be plexed if your PML was asymptomatic at presentation and if you had lower JCV copy numbers. And the bottom line was that there was no advantage to plexing patients in terms of survival at 2 years. And this perhaps is an easier way of seeing that. So essentially, lower risk of death to the left of the line, high risk of death to the right of the line. If you're asymptomatic, you do better. We know that. If you're older, you do worse. If you're male, you do worse. If you have widespread MRI changes at baseline, you do worse. If you have higher JCV, you do worse. Plex doesn't appear to make a difference. And very similar results for an EDSS of 7, in other words, not being able to walk. Mirtazapine, the systematic review concluded that there wasn't conclusive evidence to use it, but unusually for a systematic review, then went outside of the results and suggested you may as well give it because it's safe and it's unlikely to cause problems. Mefloquine doesn't work, at least in this study, which didn't include any patients with MS. Iris management, again, Mike Vochki's has done a lot of work on natalizumab-related PML and iris, and I commend you to look at some of his publications. Iris looks very much like we said, the stippled or the punctate appearances you can see around what looks like a really aggressive advancing edge. You imagine all of these cells piling back out of the peripheral immune system into the central nervous system to try and kill off the JCV. So this is where the Maraviroc may have an effect. And again, these are case reports, but you might want to have a look at these because essentially this was asymptomatic PML. You can see the stippling again. This is now PML with iris, and again you can see more of that punctate appearance. And this is, if you like, post-PML. And essentially the patient fluctuated. They took Maraviroc, they did well. They stopped taking the Maraviroc, they got worse. They went back on the Maraviroc, they started to improve. So that was the issue really around using Maraviroc, and there's a couple of case studies that suggest similar things. What about steroids? The bottom line is you don't give steroids prophylactically to prevent iris. And in fact, this study suggested that if you take, so this was before steroids in people with MS and 7 days after steroids in MS, and basically you reduce the immune response to the specific immune response to JC virus. So it's very important to use steroids judiciously, and I think that's one of the key, certainly has been in our experience with our 3 cases. When do you do it? And that's probably the thing that we've disagreed with and had most animated discussions about. I've talked about the Marivirox, so you can look at those. And again, the mechanism appears to be blocking these CCR5 cells getting into the central nervous system and causing too much immune reconstitution with the associated changes. Gordon mentioned granulocyte colony stimulating factor. Again, not a huge amount of evidence around that. And I think that's the million-dollar question really for these small groups of patients, because there aren't clinical trials. What do you do when the patient survives PML, and how do you manage them? And I think most of us at the moment are probably sitting on the fence with glutathione acetate. I'm aware that there are colleagues in other countries that are being a bit more bullish in terms of what they're offering. So avoidance if possible, clinical vigilance is the key. If in doubt, repeat the clinical tests and the assessments, and we do need clinical trials through whichever method we can obtain them. So thank you very much. I hope that was helpful.
Thank you.